Good morning, everyone. I'm Dr. Ramohan. The topic today is novel treatment strategies in rheumatoid arthritis. My moderator is Dr. Altash. We'll be talking about it in the following headings. The pathophysiology. The synovial tissues are the primary targets of the autoimmune inflammatory process. Once rheumatoid arthritis is initiated, the synovial tissues throughout the body become the site of a complex interaction of immune cells, that is T cells, B cells, and macrophages with synovial cells. The ultimate result is Pannas formation. Pannas is synovial tissue proliferation. It is considered to be a late and irreversible manifestation of rheumatoid arthritis. Its infiltration into bone and cartilage gives rise to deformities. We need to understand the mediators, especially cytokines and receptors involved in the pathophysiology of rheumatoid arthritis. This is when we will know how and where drugs act. From these figures, it is clear that interleukins 1, interleukin 6, TNF alpha are the major mediators in the pathophysiology of rheumatoid arthritis. Coming to treatment strategies, in the past, about 1 to 2 decades ago, the recommended treatment approach was slow and steady. It was referred to as the pyramid, where the base of physical therapy and non-pharmacological interventions was then followed by conservative treatment with NSAIDs, glucocorticoids, and finally DMARDs. But in the recent decade, this concept has been inverted and intensive intervention has now been adopted. The one on the left is the old pyramid, the one on the right is the new one. Now, NSAIDs are considered to have only an adjunctive role in the management of rheumatoid arthritis. Steroids are considered to be a bridge in the treatment, wherein they will act until DMARDs take full effect. And finally, DMARDs, which are considered to be the backbone in the management of rheumatoid arthritis. Novel approaches. We need to know some certain principles in the management of rheumatoid arthritis. The RA is a lifelong process that has no known cure. It can only maintain remission. The goal of therapy is remission, which refers to reduction in the signs and symptoms, slowing the disease progression, and improvement in the function of the patient. Essentially, all rheumatoid arthritis patients must now be treated with DMARDs. Current recommendations suggest initiating treatment with methotrexate and an NSAID with or without corticosteroids, and later we can move on to biological DMARDs and targeted DMARDs. This is the 2019 updated EULAR RA management recommendations. There are 5 overarching principles. First, treatment of patients with rheumatoid arthritis should aim at the best care and must be based on shared decisions between patient and rheumatologist. Second, the treatment decisions are based on disease activity, safety issues, and other patient factors. What it means is treatment must be tailored for each patient. Third, rheumatologists are the specialists who should primarily care for patients with rheumatoid arthritis. What it means is physician must also refer for consultation with rheumatologist in every case of rheumatoid arthritis. Fourth, patients require access to multiple drugs with different modes of action to address the heterogeneity of RA. Heterogeneity of RA refers to the variation in the presentation of rheumatoid arthritis patients. And 5, the rheumatoid arthritis incurs high individual medical and societal costs. We know that biological DMARDs and targeted DMARDs are mostly out of reach of most ordinary people. Coming to the individual drugs, disease modifying anti-rheumatoid drugs. They are effective in treating both early and more advanced RA that remains active. They take about 2 to 6 months to exert their maximal effect. That is why steroids are included initially. All require some form of monitoring because most of the drugs are known to cause different toxicities, especially liver toxicities. Next, critical factor is not which DMARD to start, but rather getting the DMARD therapy started early in the disease process. Coming to divisions and DMARDs. First is conventional DMARDs. The drugs are hydroxychloroquine, sulfasalazine, methotrexate, leflunomide, and also azathioprine. Methotrexate is the most commonly used conventional DMARDs. If that cannot be used, then we can use azathioprine or leflunomide. Coming to biological DMARDs, based on the central role played by cytokines and cell surface molecules in the pathophysiology of RA, biological DMARDs are used. Physicians should be aware of the risk of infections that are often atypical in patients who receive biological DMARDs. Biological agents should never be used in combination with each other because the risk of infection will become profound, and we as physicians should keep a low threshold in investigating the patient who comes with signs such as sore throat and fever. This figure summarizes the essential mechanism by which various drug classes act, mainly TNF alpha targeted therapy, IL-6 inhibition, IL-1 inhibition therapy, T cell targeted therapy, B cell targeted therapy, JAK pathway inhibition has been studied, and we have FDA approved drugs only for these classes. Anti-TNF agents. TNF alpha is a critical upstream mediator of joint inflammation. Anti-TNF agents should be avoided in patients with active infection or history of hypersensitivity to these agents, and is also contraindicated in patients with chronic hepatitis B infection or class 3, class 4 congestive heart failure. This figure shows the importance of TNF alpha in the pathophysiology of rheumatoid arthritis. The examples are infliximab, etanercept, adalimumab, golimumab, and certolizumab. These agents have common toxicities, which is increased risk of bacterial fungal infections. Reactivation of latent tuberculosis is also a risk. That is why before initiating these agents, patients must be tested for latent tuberculosis or vaccination. That is through Mantoux test or IGRA. Common brand names are infliximab and etanercept. Coming to anakinra, this is an interleukin-1 receptor antagonist. It has seen only limited use for the treatment of rheumatoid arthritis because of the requirement of daily injections. Interestingly, anakinra has exhibited improved cardiac contractility even within 3 hours of a single administration. Therefore, anakinra should be considered for patients with severe or refractory pericardial disease and or heart failure. Next, abatacept. It is an example of T cell targeted therapy. It inhibits the co-stimulation of T cells by blocking CD28 and CD80/86 interactions. Once T cell is activated, it releases several mediators which causes activation of other cells like B cells and macrophages. Hence, activation of T cells is prevented by abatacept. Coming to rituximab, it is a chimeric monoclonal antibody directed against CD20, which is a cell surface molecule expressed by most mature B lymphocytes. It depletes niches of B cells through antibody-dependent cellular cytotoxicity. If the population of B cells are less in the joints, then the signs and symptoms of the patient will come down. PML is a rare association. This is the mechanism of action. Rituximab will cause apoptosis of B cells. Coming to IL-6 inhibition. IL-6 can be inhibited both at the receptor state and at the free state. IL-6 receptor inhibition is through tocilizumab. IL-6 free inhibition is through sirukumab, but that is not FDA approved. Coming to tocilizumab, it is a humanized monoclonal antibody directed against the membrane and soluble forms of the IL-6 receptor. The contraindications are an absolute neutrophil count less than 2000 cells, platelets less than 1 lakh cells, or ALT or AST is more than 1.5 times upper limit of normal. The dosage is IV, initial 4 mg per kg once every 4 weeks. It may be increased to 8 mg per kg once every 4 weeks based on clinical response. And remember, tocilizumab is a biological DMARDs. It should not be used in conjunction with other biological DMARDs because the risk of infection will become profound. Side effects are mainly endocrine and metabolic. It causes increased serum cholesterol and it causes increased aminotransferases. And infusion-related reactions are common to most biological DMARDs. FDA has also approved sarilumab, a new biologic for the treatment of RA, a human monoclonal antibody which is directed against the alpha subunit of IL-6 receptor complex. It has a unique structure and higher affinity for receptor compared to tocilizumab. This is the common dosage for rituximab, abatacept, anakinra, and tocilizumab. As you can see, risk of infections is common to all the DMARDs. PML is a relatively unique side effect of rituximab. Coming to denosumab, this is a monoclonal antibody that binds to RANKL, a receptor, and blocks the interaction between RANKL and RANK and prevents osteoclast formation, leading to decreased bone resorption and increased bone mass in osteoporosis. It is not approved by FDA. It has found an off-label use in rheumatoid arthritis to reduce bone destruction. It is given subcutaneously, 60 mg or 180 mg as a single one-time dose and repeated at 6 months. Here, active osteoclasts have receptors called RANKL, and RANK is produced by osteoblasts. The interaction between RANK and RANKL is inhibited by denosumab. Coming to the newer agents, in DMARDs we have conventional, we have biologic, and we have the newer ones called small molecular DMARDs. They are also known as JAK-inhibitors or targeted DMARDs. Most of the agents that we have studied till now, they have acted on cell surface receptors or free cytokines, but these agents, small molecule DMARDs, act on the intracellular pathway. Coming to tofacitinib, it's an oral agent that acts by inhibiting Janus kinase 1 and Janus kinase 3. It is given in the dosage of 5 mg BD, and it was approved by the FDA in May 2018 for treatment of moderate to severe RA refractory to DMARDs. It can be used as a monotherapy or in combination with methotrexate. Possible side effects include elevated serum transaminases, neutropenia, increased cholesterol levels, and elevation in serum creatinine. These patients, before initiating on tofacitinib, we have to vaccinate for herpes zoster. Others, as small molecule DMARDs, are baricitinib and pefacitinib. They are both FDA approved. So pefacitinib was approved only in Japan. FDA approval is awaited. Now, prevention of rheumatoid arthritis. Can it be prevented? Many studies are underway trying to assess whether rheumatoid arthritis can be prevented. This concept only applies to those patients who do not meet the EULAR criteria for rheumatoid arthritis but have features such as some swollen joints or others who are anti-CCP positive and have arthralgia. Such candidates have been studied in trials, for example the PROMPT trial, comparing treatment with no treatment to prevent the onset of rheumatoid arthritis. It has been found that those who are positive for anti-CCP antibodies with an elevated BMI are more likely to develop rheumatoid arthritis. And medications have been used such as methotrexate, intra-articular steroids, sulfasalazine, infliximab, etanercept, abatacept, and rituximab. They might deal or even prevent rheumatoid arthritis onset, but when the treatment is stopped, the advantage seems to wane. But at present, there is no conclusive evidence that we can prevent rheumatoid arthritis. The summary is, once rheumatoid arthritis is diagnosed using the EULAR criteria 2010, immediately treatment is initiated with methotrexate. Methotrexate with prednisolone. Prednisolone will act as a bridge therapy till methotrexate is fully active. It takes about 2 to 6 months. If methotrexate cannot be used, then leflunomide or azathioprine may be used. Now we should look at remission. If remission is present or not. If remission is achieved, then that must be continued, the same regime, methotrexate with tapering of steroids. If remission is not achieved, then we look at the favorable factors, unfavorable factors. If there is high disease activity or anti-citrullinate protein antibodies positivity, early joint damage, then we should add a biological DMARD or a targeted DMARD. We can use a combination, but remember that we cannot combine biological DMARDs with one another, or we cannot combine targeted DMARDs with one another. And then we look at remission. If there is remission, we continue the same regime. If not, we only use different drugs in the same class. These are my references. Thank you.